Thank you, Alyssa, and welcome everyone. We're glad to have you here today for our webinar. And we're particularly excited to have Dr. Kapika here today to share with us some great information. Before we get started, please feel free to answer, do some of our pre-polling information, of course, like all grants and other projects that you're all familiar with. We like to do great evaluation work. So please feel free to answer these questions. For those of you who have a smaller screen, you'll just be able to scroll down on the right-hand side of each of those pods and be able to put in your answer. We're excited to have you here today to learn a little bit more about the great work that Deanna has done and the many colleagues that she works with. And Deanna also has consented to stay over a little bit, so if we have a lot of questions today, that's going to be nice. We generally do, and so it'll be great to have her be available to stay with us a few extra minutes as we go along. I'm excited that we have this webinar today as our continuing series as a grantee with the Centers for Disease Control to improve HPV vaccination rates throughout the country. The National AHEC Organization is a membership-supported organization to support and advance AHECs across the country. There are over 300 AHEC entities located in 45 states. Many are affiliated with multiple community-based programs, providers, and academic institutions. And individual AHECs provide a variety of programs and services to support the recruitment and retention of health professionals, expand health profession education and training to rural and underserved communities, and to support health professionals, particularly in rural and underserved communities, to receive the education that may otherwise only have been available in a rural community. And especially in days with COVID and all of the restrictions we have, the ability for us to provide educational opportunities via webinar has just been wonderful to do. At the end of our presentation, we'll also be providing you with another opportunity to evaluate the presentation as a whole, but also to find out about Deanna's second presentation, which will be held next week. And so we hope that you will be able to register then and participate. Both of these webinars will be archived so that you can listen to them post-activity or share them with people in your office who are unable to attend. And we will send those of you who have participated information about when those archives will be ready. And then we'll also send it to those who are unable to come today. So if you know of a colleague who just couldn't come, you're not going to have to do the work. If they've registered, we'll do the work for you. So hopefully that will make it all set. This presentation today and the one next week do not have continuing education credits. However, we do know that many of you can receive continuing education credits if you obtain a certificate of attendance. We also would have information available for you on Deanna, her credentials and experience, and then also her objectives. So if you need those type of things, please let us know and we'll be happy to provide those. So let's move over to kind of get started here. I'm going to let Deanna share mostly about all of her great experience. There's a lot to talk about. I have been very blessed to meet Deanna through her work with the Intermountain West HPV Vaccination Coalition and throughout this grant to go out and visit, be a participant in some of the many activities that she does, she has done. She's just like this one person whirlwind of energy that is really committed to the HPV vaccine and improving the vaccination rates across the country, and it's just always so exciting to hear from her. She's an associate professor at the College of Nursing at the University of Utah. I'm really proud about that because I'm also an alumni of the University of Utah, and it's just a great place. If you ever have a chance to go, be sure to go there and visit the Huntsman Cancer Institute, where she's also an investigator and an integral part of the work that they do. She has a variety of other titles, like I said, the founder and developer of the Intermountain West HPV Vaccination Coalition, and also the director of the Global and International Health at the College of Nursing at the University of Utah. So we're really in for a treat. With that, I am going to turn it over to Deanna for her to get started. Remember to feel free to add any of your questions as we go along. We'll be happy to answer those. and I know you're in for a real treat. So with that, I'm going to turn it over to you, Deanna, and you can get started.
Thank you so much, Gretchen, for the very kind introduction. It was so thoughtful. It's really exciting for me to be here today. I'm looking at my computer and I was like, wow, there are over 200 people logged in from all over the country. I think this is the most social I've been in 4 months. So I'm really honored that you've all carved out some time in your day to spend some time talking and listening to our work on HPV vaccination, with a focus on improving HPV vaccination rates in rural settings. Okay, so sorry about that. So a little bit about me. I've been in Utah for about 8 years. One of the factors that drew me to the Mountain West was the chance to work on HPV vaccination in this region that is largely rural and has some of the lowest HPV vaccination rates in the country. I did a postdoctoral fellowship at the National Cancer Institute and completed my PhD at the University of Washington. I've been working in HPV vaccination since around the time the vaccine was approved for girls in 2006. I did my dissertation in the Yakima Valley, and I noticed there's some people on the call from the Fred Hutch, and that's where I completed my dissertation work. And what has drawn me to HPV is the motivation that we have this vaccine that is this true gift of cancer prevention that has been slow to be adopted. And yet, if anyone who has cancer, anyone who's been affected by cancer, I recently just lost a brother-in-law, age 51, to cancer. If any of our friends or family members who've been impacted by cancer had that opportunity for a vaccine, just 2 doses to prevent all their pain and suffering, we would jump on it. And that's what we need to do, is reframe this as this true opportunity and true gift. And what I'm going to focus on today is the disparities we see in rural vaccination and why that's so problematic and what we can do about it. Feel free to type in questions after you've all signed in where you are, where you're located. I love seeing all the different locations. I find it very exciting. I feel socially connected with people, which I haven't for a while. So let's get this going. These are the objectives for today's presentation. We're going to briefly go over HPV vaccination guidelines. I'm sure on the call we have everyone from HPV novices to HPV gurus, so I'm not going to belabor this too much. But then we're really going to dive into these differences in rates of HPV vaccination in rural versus urban settings. We'll explore barriers that may be impacting why rural communities have lower rates of HPV vaccination, briefly discuss the potential impact of COVID. And I know this could be a whole talk in itself, looking at COVID-19 on teen immunization rates, but I do feel that we need to at least touch on it briefly, because we are in this new world that has been devastated by this pandemic, and I don't think we can give any sort of public health scientific talks without at least addressing some aspects of how COVID is related to our new world. And then we'll talk about some ideas for future directions that are needed to improve HPV vaccination in rural settings in the United States. Please let me know in the text box if I need to talk louder or slower. I want this to be an enjoyable experience, so just let me know how I can best make it a positive experience for you. I'm getting used to using arrows and not my return key, so here we go. These are the guidelines, the most up-to-date CDC Advisory Committee Immunization Practice HPV vaccination guidelines. They were put into effect in 2019. I think the biggest issue is that HPV is supposed to be routinely recommended at ages 11 and 12. It can be given as young as 9, and anyone who is not vaccinated up through 26 should hands down get that HPV vaccine. From age 27 to 45, this is when you need to have a discussion with your provider and have shared clinical decision making to look at if the vaccine is beneficial for you. Over age 45, the vaccine is not currently licensed. So the dosing schedules, intervals, and definitions of persons considered adequate to be vaccinated have not changed, And please know that no pre-vaccination testing is recommended for receipt of the HPV vaccine. So regardless of any TAP or HPV test results, women and men up through under age 27 should receive the HPV vaccine according to the AHEC guidelines. So one thing I'd like to emphasize is that it's important to start talking early about the HPV vaccine. Here in the Mountain West, we realize if we start bringing up the HPV vaccine at age 9 and 10, a lot of times parents are more accepting of getting the first dose at 9 and 10 than when it's sandwiched during that early adolescence, prepubescent or pubescent time. And another thing about giving the dose early, when they come back for their annual visit at 10, then they can get the second dose. An on-time HPV vaccination is at ages 11 and 12. Let me repeat, ages 11 and 12. It is supposed to be sandwiched and recommended with the other adolescent immunizations that are supposed to be delivered at this time, as recommended by the AHEC. Now if you wait till 13 and 14, which I would say is the most common ages we're seeing kids getting vaccinated are up to those late teens, you're late. And if you don't wait until 15, then you all of a sudden have an extra dose of the HPV vaccine. So why is it so important for our children to receive the HPV vaccine? Why is this so critical? Why have I dedicated more than a decade of my professional life to this, and a lot of my personal life too? Because the thing about HPV is who has it? I do, you do, we do. Nearly all of us have had or will have HPV. It is the most under-discussed, less frequently talked about, most common sexually transmitted infection in the world. Yet it is pervasive. We should not be stigmatizing HPV because you know what? We all will have it. Nearly all of us will have it. And you know what? In the United States, about 34,000 cancers are caused by HPV each year, and about 32,000 of those are preventable with HPV vaccination. So this is our Rice-Eccles Stadium here at the University of Utah, and I give this for my Utah talks because it is as if we could prevent a cancer for every single person sitting in the stadium on a yearly basis. And think of all the impact that that has on not just the individual person's life, but their family, their friends, our economy. And now, most people have associated HPV with the prevention of cervical cancer, but it's not just cervical cancer that HPV causes. It causes oral, anal, vaginal, vulvar, penile. So there are many different types of cancers, 6 different types of cancers that are caused by HPV. And what I'd like to highlight in this is most recent data looking at HPV cancers by gender. So you see in women the most common cancer is cervix, but we also have high rates of anal cancer and then some oropharyngeal and vulva. In men, however, the highest cancer, HPV cancer incidence is oropharyngeal. And the thing about oropharyngeal now is most often there's been an over-feminization of the HPV vaccine, where people associate it as a vaccine to prevent women's cancers. Yet, the most common incidence cancer right now is cancer of the oropharynx in men. So men have the most common HPV-related cancer right now. And oropharyngeal cancer is increasing. This is a breakdown, and I like to show this slide because I like to show, and I'm so happy CDC updated it because I was showing a previous slide before, and I just found this new slide yesterday, that when you look at the HPV vaccine, the quadrivalent vaccine, the original vaccine included protection against 16 and 18, and so did Cervarix. But now the nanovalent vaccine has added these other HPV types, 31, 33, 45, 52, 58. So I call the 16 and 18 the tsunami HPV types. They are causing the majority of HPV cancers. You can see they're the darkest blue. And then the medium blue are all the added protection that we're getting from the nanovalent vaccine. And now white are cancers that are caused by HPV that are not included in the HPV vaccine. And this underscores, again, why PAP testing and HPV co-testing continue to be a priority for cervical cancer prevention. because we're not going to prevent it even with vaccination. Furthermore, a comment I'd like to make about the oropharyngeal cancer life history is that we do not have an FDA-approved test to detect precancer in the oral cavity that is linked to HPV in the way that we have for cervical. So the for oropharyngeal cancer prevention, for HPV oropharyngeal cancer, the vaccine is the first and only line of defense. Where cervix, we have the vaccine, which is the most important, most powerful line of defense, but then we also have the ability to detect precancers before we get to cancer with HPV co-testing and PAP testing. So that's why for men, we really need to get these vaccine rates up as being the highest incidence of HPV oropharyngeal cancer, and then also with a lack of screening. We have a lack of FDA-approved screening for cancer, HPV-related cancer in the oral cavity. Oh, here's the tsunami types and then the runner-up. So those are the 7 types that are included in the nanovalent vaccine. The other bonus of the nanovalent vaccine and the quadrivalent, but we only use the nanovalent vaccine now in the United States, is it gives protection against HPV types 6 and 11, which cause more than 300,000 cases of genital warts each year in the United States. That's 1.5 times Salt Lake City. And I don't know about you, but if you could prevent genital warts, I think all of us would do it with a simple vaccine. And although genital warts are not going to have a tremendous impact on morbidity and they won't affect mortality, women can pass HPV types 6 and 11, can pass it to their children during childbirth, which could result in recurrent respiratory papillomatosis, RRP, in a child's throat, where a child would have recurrent respiratory papillomatosis, which are warts in their throat that they would have to have surgically removed. So even prevention of HPV 6 and 11 can affect the health of children. Not to mention cosmetically and aesthetically, we all would love to prevent genital warts. And with this vaccine, we can do it. Now, here's a little quiz. I'm integrating some quizzes, so please type your answer into the chat box. So I just want to see if you're paying attention, because that's the thing about our COVID world, is most of us are working a little bit remotely, and so it's nice to have a little interaction during a presentation. So I'm so excited to see we've got so many superstars right here. A child receives the first dose of the HPV vaccine at 14. She comes back for her second dose at age 16. How many doses does she need? If a kid receives the dose before age 15, she only needs 1 more dose. And again, that's a bonus to receiving that HPV vaccine, the first dose before age 15. So congratulations, all you superstars who got the answer right, which is a good chunk of you. You only need 1 more dose if you begin the vaccine before age 15. Here's another question. So we're on question 2. The HPV vaccine is FDA approved to prevent which types of cancer? Cervical, vaginal, anal, oropharyngeal, all of the above. And again, we've got a lot of smarty pants in the room. Recently, I think it was just maybe 3 weeks ago, it was definitely in the last month, the FDA has now also approved the HPV vaccine for the prevention of oropharyngeal cancer. So the answer is D, and this is exciting news for all of us who are in the public health field, because it was a little bit challenging to say the vaccine prevents 16 and 18 HPV types, and these types cause the majority of HPV oropharyngeal cancer. Well, now we can say the HPV vaccine is recommended and approved for the prevention of all of these cancers, including oropharyngeal. So let's dive into rural versus urban disparities on HPV vaccination. I'm going to take a quick sip of water. And thank you so much for all of your active participation. I'm so glad that all of you have been following the news and are up to date on the recent approvals. So when we look at the map of the United States for HPV vaccination rates by state, I would say the #1 predictor or social determinant of whether or not you receive the HPV vaccine is where you live. So look at this sprawl in differences from the white state to the black navy, dark navy blue black state. You've got vaccination rates that are a third in some states up to date to almost up to 80% in other states. This is a huge disparity, and this is a huge difference in HPV vaccination rates that are largely due to the social determinant of where you live. They correlate with your state of location. And when you look at a lot of the white states with the lowest HPV vaccination rates, many of them have very large rural populations. I know in the Mountain West, in the region that we serve at Huntsman Cancer Institute, we're largely rural and frontier. So we have many, many very dispersed populations over our 5-state region. And if you see in our 5-state region, which is Utah, Nevada, Idaho, Wyoming, Montana, 3 of our states have really low HPV vaccination rates. And the CDC Healthy People 2020 goal was 80% HPV vaccine completion. So we've still got a ways to go. We're in 2020. We still have only about 51% of our kids completing the series in 2018. I'm looking forward to the new data for 2019, which will come out in August. They almost always come out in August. Maybe it'll be a little different this year with COVID. And then I am concerned about the data that we're going to see for 2020 as a result of the pandemic, which we'll get into a little bit later. But we still have a ways to go. We've set this goal for over a decade, and we still have quite a ways to go to reach that goal. And in some regions of the U.S., we have a long ways to go to get to 80% HPV vaccination completion. And I'm going to discuss with you the regions that I see by geographic composition that have the lowest rates of HPV vaccination. So when you look at, these are classifying it, U.S. average is in orange, urban blue, pink is rural. We see across the board for girls, 1 dose and up to date is lower in rural communities than in urban. And for boys, we see 1 dose.
Deanna, are you still there? Hold on, folks. Let's see if we can find her.
Hello? Hello?
Are you back, Deanna?
Yeah, I'm back. I'm not sure what happened. I didn't touch my phone.
Okay. That's
We're
okay. It could have cut out.
Yeah, we're glad you're back, though.
Okay. I'm so sorry that I lost you. I don't really know what happened. Honestly, I had my hands very far away from my phone. So
It happens. It's all set for you.
it was a mystery. Okay. So what we're showing here is that across the board, and this is 2017 NIS team data, we're seeing lower rates of HPV vaccination for both 1 dose and completion among females and males. Now, this is a really fabulous report, and I recommend going to this link below to look at closing the gap in HPV vaccination for rural settings in the United States. It's a fabulous report. I'm going to share quite a few slides from it. So what now I'm going to break it down a little bit more. So this is looking at metropolitan statistical area principal city. So that's the same as urban. Non-principal city, that is not rural, but still maybe a smaller city or suburban. So non-principal city, smaller population, but still more populated than rural. And so we're seeing here that we're looking at vaccination rates for, there's 3 vaccines that are recommended for adolescents, and it should be bundled. It's Tdap, Menoptra, or for meningitis, and HPV. The flu vaccine is also recommended, but the HPV was designed to be bundled with these other 2 vaccines, Tdap and Menoptra. And so what we're seeing here is that for Tdap, there isn't really a large difference for rural, which is the navy blue, compared to non-principal city and urban. However, we are seeing lower rates for Menoptra in rural settings, for first dose of HPV, and for up-to-date HPV. So all the stars recommend statistically significant. And we're also seeing lower rates for first dose and HPV in the non-central city, the non-principal city regions. Can folks see my slides? I got a text that people can't see my slides. But I'd like to hear why you think maybe we don't see a disparity for Tdap where we are seeing for Menoptra, HPV, and completion of HPV. Give it some thought, and we could discuss it a little bit later. But let's think about this. We see this disparity for Menoptra. We see this disparity for Menoptra. We see it for HPV. We see it for up-to-date, but we don't see it for Tdap. So we have exactly, Tdap is required for school. And Menoptra is required for schools in some states, not all states. So I think that is the major difference, is the Tdap regulation for schools. Now when we look at, again, we're looking at stratification by gender. So again, we see rural first dose HPV vaccination rates significantly lower for females and for males in the most rural communities compared to the principal city, urban areas. But then we also see lower rates for the non-principal cities. So I think this is interesting. That it's a stepwise situation. So more rural, lower rates of vaccination, and less urban. Now again, when we look at racial and ethnic groups, we see a few other differences. So we see these lower rates of HPV vaccination for first dose among all adolescents for whites in rural communities and in the non-principal city compared to urban areas. We also see this huge difference for Hispanics, but 12 percentage points, 14 percentage points difference for rural Hispanics. And I really underscore this as a huge factor that we should be considering, because we do know that there's a disparity in cervical cancer incidence among Hispanics. There's also a disparity in HPV-related penile cancer among Hispanics compared to whites. So if we don't get this uptake up, these disparities are going to widen. We see lower rates for rural African Americans, but it's not statistically significant. So we see lower rates, but not statistically significant. Great discussion going on. So now let's look at, so we're looking at the same thing, the principal cities, and we're looking at the race ethnicity. And again, it's what I was talking about before. When we look at stratified by poverty level and MSA status, we're seeing a similar pattern across those who are below poverty and above poverty, with lower rates of HPV vaccination in rural settings, which are the darkest red, for those who are below poverty and also for those who are above poverty. And I would like to show here, this is an interesting artifact of HPV vaccination. We do see lower rates of HPV vaccination among higher income people across the board in the United States. So we're seeing the lowest rates of HPV vaccination among higher income rural folks. And then we still continue to see lower rates among lower income rural folks. And the same follows for those in the non-principal cities. So the trend continues across all these different characteristics. So I wanted to also highlight that fabulous report that you can click on at the bottom, used 2017 NIS teen data. So I want to share a little bit with you about, are we seeing the same thing using the most recent NIS teen data? And we are. So these are the 2018 data, which are the most recent. We'll be holding our breath for the 2019 data, which should be coming out again in August, hopefully by the end of August. And again, when we look at HPV vaccination in the rural communities, the non-MSA, non-metropolitan statistical area, we see 16% lower rates of completing the vaccine in rural and about 12% lower rates for first dose in rural than urban. So these trends continue when we look at the last year of data. All right. So rural or non-MSA regions tend to have lower rates of all adolescent immunizations. Is this true or false? You can put an A or B. Feel free to give your response. So what we saw in the data a little while ago is that this is false. We did not see statistically significant lower rates. Let me go back here. We did not see statistically significant lower rates of Tdap immunization for rural settings. But we did see statistically significant lower rates of HPV and Menactra, or meningococcal vaccination for, I'm not getting the text that I had there, but it's okay. Oh yeah, right here. So we're not getting the lower rates that we had. Tdap tends to stay the same. It's similar, where HPV and Menactra tend to be lower in rural settings and in semi-rural settings in the non-metropolitan statistical areas. So the correct answer was B for that one. Now, when I look at why is this so important, like not only do we want everyone to reach the Healthy People 2020 goal of 80% vaccination for HPV up to date among teens, but why should we be extra concerned that our rural communities are lower, with 20 up to 10 to 20% lower in different communities across the United States? And this is what motivates me to work in HPV vaccination in rural and frontier settings. I'm going to flip one thing. Sorry, I saw a question. It was related to all vaccinations, not just HPV, so I apologize if the question wasn't written as well. So this is what we're looking at. When we look at non-metropolitan cervical cancer mortality in rural settings in the U.S., the red line is consistently higher than metropolitan, consistently higher cervical cancer mortality in rural settings in the U.S. over this large span of years, almost 60 years. And this could be largely due to the late-stage diagnosis that I'm seeing in the chat box. And then when we look at cervical cancer mortality trends by race, we see a similar pattern where non-metropolitan whites have greater cervical cancer mortality than metropolitan whites. And then even more exasperated is non-metropolitan Black compared to metropolitan Black. We see a greater increase in cervical cancer mortality among rural African Americans than urban African Americans, but all African Americans have higher cervical cancer mortality than whites. So again, these are health disparities coming to the forefront and really underscoring the importance of getting those HPV vaccination rates up to NIS teen 2020 goals for all of our population, with a focus on improving in rural settings first. And now when we look at, these are more recent data, so these are data from 2009 to 2013. I just want to show you that these are data that are combined for all HPV-associated cancers, so it's not just cervical, but it can include anal, oropharyngeal, other HPV-associated cancers too. we see higher rates of HPV-associated cancers in rural versus urban. So you see 12.6 is the rate probably per 100,000 versus 11.7 per 100,000. But then when you look at females, that's really what's driving this difference, because for males, you see 9.9 per 100,000 in rural versus 10, very similar figures. But for females, we see 15.2 compared to 13.4. So a lot of the differences in rural versus urban HPV-associated cancers are related to female HPV-associated cancers. Now, again, when we look at regions of the U.S., I wanted to show you that across the board, rural settings have higher rates of HPV-associated cancers in the Northeast, in the Midwest, in the South, and in the West. But we see the largest disparity in HPV-associated cancers in the South, the greatest 1-point difference here. All right, we're going to move along. Got a lot to cover. So why are HPV vaccination rates lower in less metropolitan rural communities in the U.S.? And I've been seeing a lot of discussion, and I keep getting distracted because I want to be social and I want to see what people are saying, but I'm going to focus on the content and then go through the questions at the end. But this is like, I feel like these are the most important factors on why we're seeing lower rates of HPV vaccination. And these factors, where is this information coming from? This is coming from my personal literature reviews and also my experience in doing, I've done about 25 trainings in rural and frontier clinics in the Mountain West for HPV vaccination improvement, and then I've also done a series of studies where I've done many focus groups and surveys. So I'm going to get into some of those data. But this is what I'm seeing is happening in the rural settings. And I'm listing these by what I think is super important and is driving some of these disparities. The strong provider recommendation can be less likely to happen in rural practices. And sometimes it's that it's not as consistently recommended by the whole healthcare team. So maybe the clinician's recommending it, but the nurses, the medical assistants, the front office staff aren't as enthusiastic about bundling this HPV vaccine and getting kids vaccinated. They may have comments like, you know, oh, you're getting that vaccine for your son? Oh, I didn't get it for my son. You know, I only got it for my daughter. You know, just little, like what I would call informal conversation can really influence how a parent feels. Healthcare system challenges. These healthcare systems in rural settings are smaller. They're more taxed. They're taking care of people from birth to death. They have, they're financially strained. They've got many, many more challenges. Maybe their electronic health records aren't as sophisticated. Often we're hearing from our rural providers and healthcare teams that parents and patients aren't as informed about the HPV vaccine. There's thought that it's not for such young ages as 11 and 12, and it's not for boys. That's the girls' vaccine, the feminization of the HPV vaccine. Fewer visits to primary care at this age because a lot of kids at the adolescent years are healthy. Multiple doses. Many, many parents travel an hour, hour and a half to get to rural providers if they live in frontier communities. Who wants to go back for dose 2? Who wants to go back for dose 3? Costs related to cold storage. I've been told we don't stock that vaccine because the demand is too low for us to have to store it and for it not to be used before it expires. Some clinics find that the demand is too low, and sometimes I argue the demand is low because it's not being pushed, because I feel that we create demand as healthcare teams. We create the demand for a vaccine, but the availability of vaccine may not even be offered in some small clinics. I've done quite a bit of work in smaller clinics in Nevada, Wyoming, Montana, and sometimes they don't even stock the HPV or other adolescent vaccines. They refer parents to the health department, and they'll have to drive quite a while to get their vaccine. And that's one more visit. It's another visit the parents may not be able to find time to do or be able to prioritize. And then lastly, not framing this vaccine as a cancer prevention vaccine. The major barrier that we see in HPV vaccination. So here's a little bit of a snapshot of some work that I've been doing. I received a grant from the National Cancer Institute for their P30 supplement to look at rural disparities, rural inequities around HPV vaccine knowledge, practices, uptake. So with this funding over the last few years, what we did is we conducted 14 focus groups and also surveyed all the participants of the focus groups in 4 states, Montana, Colorado, Utah, and Arizona. We went to rural and frontier settings, so the most rural and frontier settings in these regions. It was truly beautiful to go out and do this work. I really, really enjoyed it, and I was so disappointed to have to cancel, I think, about 4 visits that I was going to make this spring because of COVID. We surveyed healthcare teams, their staff, clinicians. We surveyed community stakeholders and parents and caregivers. So I'm going to give you a few snippets on our work. So these are the biggest barriers that we saw at the parent-caregiver level. So these are survey responses that we got from parents and caregivers. So it could be a grandparent or anyone who's caring for a child who would be eligible for the HPV vaccine up through age 17. They were unsure about what vaccines to get for their kids. A third of parents felt unsure about what to get. 21% were worried about the cost, even though cost shouldn't be an issue because of vaccines for children, and this is where an education strategy is needed. The time to get to the clinic, the cost of a clinic visit, scheduling the appointment, and distance to the clinic. These are all issues that parents and caregivers mentioned as challenges. On the provider side, the challenges that were mentioned: no system to remind parents for second HPV vaccine, no vaccine records. So again, these are the EHR system barriers that many rural clinics experience. No system to remind parents to talk with patients, and no standing orders for the vaccine. So really, these findings underscore parents and caregivers' uncertainty about which vaccines to get, and providers and stakeholders' desire for systems to be reminded to inform parents that they're due for the vaccine. All right, moving along. So some of our other quantitative findings is we looked at difference between clinicians and healthcare team members, and we found that clinicians have more challenges that were affecting HPV vaccination that could result in having a larger priority for HPV vaccination. They were more knowledgeable, and I think this is important in the sense that often these other healthcare team members play key roles in recommending and promoting the HPV vaccine. So we'd like to get those other healthcare team members up to speed. Clinicians had stronger recommendation practices, so again, we want to get those other healthcare team members up to speed. And clinicians were more likely to get HPV vaccine on the same day. So really encouraging that same day, same way, treating every vaccine like a vaccination visit. We really need to prioritize that, not just among clinicians, but among the whole healthcare team, because often in these rural practices, there aren't many people on the team. Everyone plays a huge role in vaccination. Okay, moving right along. I'm kind of running a little bit low on time. But here's some of our qualitative findings. So we had those focus groups, and really, you know, from the provider's perspective, it's about prioritizing the vaccine, just like any other vaccine that a kid should be given at this age, and desexualizing the vaccine. And just really trying to set good role models, because in these communities, they're small, they're tight, everyone knows everyone. So really standing up with promoting this is a cancer prevention vaccine, and it's just like any other vaccine. And then there's a need for normalizing this vaccine, stronger communication with the parents, looking at ways to confront some of their barriers, and then looking at how to improve healthcare systems to strengthen reminder and recall. Okay, so these are our qualitative data, and stay tuned. Hopefully these data will be published soon. But you know what we really found is we want to improve the training in rural settings, not just for the healthcare clinicians, but for the whole team, to get everyone on board on treating the HPV vaccine just like any other vaccine, treating every visit like an HPV vaccination opportunity, even if it's a sick child visit. It's an opportunity to vaccinate, giving that strong recommendation with the other vaccines and prioritizing it as a cancer prevention vaccine. And then furthermore, looking at how to work within the constraints of many EHR systems in rural settings. How can we work with them to best optimize what they're doing? And this is some work that my team is doing right now. And we're getting some consultant work from an expert here with the EHR system at the community health centers in the state of Utah, a system that another small clinic in a rural setting isn't as familiar with. And we're getting a consultant from the larger system to help them get more familiar with their EHR system and how to maximize reminders and maximize campaigns. I mentioned this cancer prevention, improving effective communication strategies, leveraging the technology that's available, persistence, not giving up. So often I've heard from rural providers, oh, that parent's never going to come around. But you know what? Life happens and people change their minds. So it's not giving up on a parent. Treat every visit like an opportunity for vaccination. So lower HPV vaccination rates in rural communities can lead to widened health cancer disparities, can lead to the occurrence of preventable age-related cancers among more than 20% of the U.S. population that lives in rural settings, can lead to an ongoing occurrence of cervical precancers. We haven't had a lot of time to talk about cervical precancers, but I really want to emphasize that anywhere between 1 in 10 and 1 in 5 women has had an abnormal Pap test or a positive HPV test. And really, the HPV vaccination can prevent that. And that's widespread impact. If you look at between 1 in 10 and 1 in 5 women having this negative experience in their healthcare setting. And that is correct. The correct answer is B. This is such a brainiac group. I love it. Somehow it didn't circle, but trust me when I say the correct answer is C. So how has COVID-19 impacted HPV vaccination in rural communities? So granted, this is an area that's ripe for research, and I'm going to jump on board with this with my team to learn as much as we can. But here's what we do know. We know that in the last 3 months, up to 40% of appointments for children's immunizations have been canceled. 40%, and up to 80% of appointments for teens' HPV vaccinations have been canceled. So teens are the least likely to be going for the vaccination visits right now. And I hypothesize that there's even lower rates of this happening in rural settings because they have even higher demands with the COVID climate in every way possible, from structural demands, resource demands, space demands. I know from talking to our rural settings, like they're having to move their clinics out into tents because they just don't have the space to accommodate well child visits or vaccinations or non-COVID visits to space everyone out. So we know this is going to be a huge crisis for vaccination rates this year. We know that there's this tremendous drop, and when the 2020 data come out for teen vaccines, they're gonna plummet. Yet, how do we get, the key now is how do we get people to feel safe to come back to get those vaccines? How do we get them to trust their provider to set up systems that will protect their health and help them get back in for these vaccines? And I really feel like this is a model of vaccine hesitancy that to strengthen HPV vaccination in the era of COVID, which is this black box, our public health crisis, COVID-19, we need to build that confidence that our providers and their healthcare teams know what they're doing in all settings, rural and urban, but I'm focusing on rural right now. Get those messages out that your rural clinics know what they're doing. They know how to protect you. They are recommending safe vaccines. And it's important to protect your child against this infectious disease. Make it convenient. I've heard of many clinics in rural settings do vaccines in the car, coming out and do car visits. Make it affordable. The HPV vaccine is affordable. No one should be denied HPV vaccine regardless of ability to pay because it's covered by the Vaccine for Children program up through age 18. And we need to make it important. People are saying, oh, these vaccines can wait. No, they can't wait because we don't want a repercussion of COVID to be a rise in vaccine preventable illness. We don't want it to be a crash in our opportunity to keep improving HPV vaccination rates in the United States. So what future work is needed to improve HPV vaccination in rural settings? I think a lot of future work is needed. So one of the reasons why I've made this a huge priority is because a lot of the literature that's out there on HPV vaccination, evidence-based strategies for improving vaccination have not been done in rural settings, even though we have this disparity in rural vaccination rates. I think we need more research, more studies looking at adapting these evidence-based recommendations for rural settings. What are making these recommendations trickier for rural settings? And which ones are easier to implement, like standing orders? And how can we help rural clinics use their EHR systems to the best, the highest level? How can we train providers and the whole healthcare team to make those presumptive recommendations? And what can we do for patient reminder and recall to get parents in for that first dose and to complete the series? And then looking at these planned use study act cycles as important for all of us to reflect on how we can improve the quality of our care in our primary care settings with a focus on rural settings. So I think to look at how to roll this out for adapting to evidence-based is we need to go out to rural clinics, we need to listen to them, and we need to work closely with them. We're trying to roll out each one of these one by one, looking at what challenges are happening, what do they need to help make it happen, and be as attentive as possible and as thoughtful as possible. I also think we need to look at how we can reach parents and caregivers, since many of the rural providers that we talk to in their healthcare teams said parents are not as well informed about HPV. How can we target campaigns to these parents? How can we tailor them with messages that ring true to them as rural residents in the United States? How can we penetrate social networks and gain support from community leaders like religious leaders who play huge roles in regions in the Mountain West? And how can we partner with schools and school nurses to strengthen their recommendation for this vaccine and to actually deliver the vaccine, the HPV vaccine? Same thing for young adults. The only thing I want to comment about young adults is I'm going to be doing some research on young adults and HPV vaccination in rural Mountain West settings right now, because I think so many of our young adults by age 18 have not been vaccinated because we're such a low vaccination region in the U.S. And so this gives us an opportunity to target them directly. And I think, again, we need to build social media platforms and get support from key community leaders and look at message design and how to best penetrate social networks. I'm going to skip this share your ideas. I did want to hear from you on your thoughts on how we can improve HPV vaccination in rural settings. Just to kind of wrap up, and we can talk about it at the end with whoever wants to stay on the call. Please keep in mind that this National HPV Vaccination Roundtable is a fabulous resource with hundreds of tools available that you can use in your practice. I wanted to let you know that we are the Intermountain West HPV Vaccination Coalition. Anyone can join. We have members from all across the United States. We are a webinar-based group. We do monthly webinar meetings, and you're welcome to join. Just send me an email if you want to join, and my email address is at the end of the slide, and we'll keep you involved. So feel free to participate in the closing poll. I'll hand it over to you, and then I'll take up questions at the end. Oh, yes. So we're really active. We've been involved in improving HPV vaccination in the Mountain West and learning from each other and working across disciplines. And we welcome your feedback. We have monthly speakers, and we aim to have in-person meetings. It's a little bit challenging right now, but we hope to have a couple in-person meetings next year, maybe probably in 2021 when COVID is a little bit more manageable and we have that COVID vaccine. But feel free to type your questions in the chat box. And this is my son. You know what? He's getting his HPV vaccine next week. And I'm so excited. Hudson's going to do a news story on it because it's going to be like, HPV vaccine researcher has been waiting 11 years to give her child the HPV vaccine. So I'm really excited that he's excited to do it. So feel free to email me with any questions. Call me. I'm here. I'm always looking to partner with new organizations and to learn from you. So thank you so much for your time.
Thank you, Deanna. That was very informative, as we knew it would be, and we know there's going to be a lot of little questions that pop up, and we'll go from there. I do want to thank our Crossroads Utah AHEC, located in Salt Lake City. They were great enough to ask us if they would help sort of put Deanna out on a national stage, so we're real excited that they were able to do that for us, and we'll go from there. So we do have a few questions. One of the questions is related to, is the 80% prevalence rate before vaccine usage or despite HPV usage?
I'm not following the question. What do you mean 80% prevalence?
Well, let's see if Mark will resubmit his question. We'll jump to a
So
next.
the goal is for 80% for the Healthy People 2020, 80% of teens to have completed the HPV vaccine series.
Okay.
So I'm not sure. I could pull up. I'd have to know the context for the 80%.
Well, let's jump to the next one and see what we have. Are cervical cancer death rates statistically significant when you look at those numbers that you showcased? I mean, they're significant, but are they statistically when we have to look at it that way?
Yes.
Okay.
The death rates are, because in the Kaplan-Meier curve, they do not overlap. But this is through 2007. So the more recent data I'd have, they're not as clear, but I could definitely say it's that paper through 2007. It's a statistically significant difference.
Okay. Are there many additional studies about the common reasons why people decline the vaccine?
So we know from the NIS teen data, they asked parents why they didn't get the HPV vaccine for their child, and the most common response is that it was not recommended to them by their provider.
So a secondary question related to that, Deanna, is they're not recommended by the provider. So, and you talked very briefly about the sort of little comments that happen, you know, well, I didn't get it, why would you get it type thing.
Mm-hmm.
What do you think about working with all of the staff? So not just the provider, not just the RN or the LPN. What are your thoughts on medical office assistants, receptionists? What are your thoughts on those kind of people within a clinic?
Oh, I think it's integral, and especially in rural settings where everyone knows everyone, right? So I feel like that strong, unified message coming from the whole clinic as a pro-vaccine clinic, a pro-HPV vaccine clinic is key. And so the NIS teen questionnaire asks about the provider recommendation, but we know from all of our qualitative work that the whole team's recommendation and attitudes around the HPV vaccine is important. So I'm seeing the question now is around 80% in HPV infection in the population. So that is a good question. Now the thing is, we know that there's declining HPV rates in the United States from the NHANES data. I'm not sure exactly how that is affecting the population overall yet. We have seen a decline in the HPV types that were covered in the original quadrivalent vaccine, so the 16-18. We've seen a decline using the National Health and Nutritional Examination Survey, where they actually take biological samples from women. So, but I'm not positive how that has affected rates of HPV vaccination for the population. HPV infection for the rates of the population overall. So that's a really good question. I say stay tuned and watch out for the data that comes in the years to come, because there is such a delay from the time of HPV infection to when you would see precancers and the other cancers. So I think it's going to take a long time to see population level benefit, especially when our vaccination rates have been pretty substandard. But we know countries like Australia and Canada and Rwanda are on the path to be among the first countries in the world to eliminate cervical cancer. So that's where we are seeing some positive impacts with the widespread vaccination and cancer outcomes.
Very good. Next question, what are your thoughts about involving other health professionals like dentists and nurses in providing that HPV vaccination?
I think it is absolutely critical. We've done some preliminary work here in Utah surveying dentists and their teams. I've also done some work surveying dental students at 15 different universities at looking at their interest in talking about HPV in their practice and possibly delivering the HPV vaccine. I think where we should start with that are clinics that have an associated primary care site. So dental practices that are associated with like community health centers that have an associated primary care, they should be working together to get all those dental patients in for vaccination, you know, maybe the same day as their dental visit.
Great.
Pharmacists are a little bit trickier, but definitely important too.
So any thoughts on the, you know, we had the One HPV campaign on TV that went over really well. Now there's a new one that's coming out. What are your thoughts on those kind of campaigns, particularly since we know that you talked a lot about just educating the parents in general.
I like the One Less campaign. I think it's really key. I haven't seen the newest campaign, but I'm not exactly sure what their tagline is. But I like looking at how parents can prevent, a future cancer. I think that should ring true for all of us because all of us have been impacted by cancer. I think in rural settings, I think we need more community leaders standing up and saying this is cancer prevention. How can you miss this opportunity for your child? We have the opportunity to embrace this. Or how can we look at it being still living, a lifestyle that promotes the cultural norms, but taking the opportunity to prevent cancer because you can. So I'll have to look at the new HPV campaign. Who put it out, Angela? You could just text it, and I'll have to look at it.
So one other question that, it was a series of questions that were coming up, and they were related to VFC. So can you talk just a little bit about the whole VFC issue, VFC in rural communities, who has it, who doesn't, and all of those kind of issues that came up? I know when we were talking, the chat was kind of going crazy with VFC works in one state, but it doesn't in another. It works in this rural community, but not in another rural community. Thoughts on that?
So I have a few thoughts. I mean, what I can say about VFC is even the majority of health departments should be offering HPV vaccine as a VFC option. I can say in Utah, we have a health department, the Southwest Health Department, that does not offer HPV because the medical director there does not support the HPV vaccine. So there are exceptions. I know in South Carolina they have some issues too. But the thought behind VFC as a federally funded CDC program that it should be making the vaccine available to all kids everywhere. And in most of Utah, that is everywhere except for that one health department. And parents should be able to get the vaccine regardless of ability to pay. They may have like an administrative co-payment for the vaccine, but if a parent cannot pay it, they should not be denied the vaccine because of that. So in theory, it's for everyone. In practice, there have been some workarounds. And for some communities, it can be a haul for parents to get to the health department that offers it. So those are my thoughts.
Yeah, very, very true. Not only the distance, but even those states where I know in Nebraska, if you can't get it in certain places, yes, you can get it from the Community Action Agency or the health department, but they only come out on the second Tuesday of every month. Well, if you miss it, then, you got to wait another month. And if it rains or, whatever it might be, and those are all obstacles with very well-meaning parents who want to be there. So, yeah, it is a struggle. Well, Deanna, wonderful presentation. Lots of great questions, lots of great information. And I know that everybody is jumping right now to what's on the screen, and that is to come back for your next webinar next week to talk even more about how delays in HPV cancer diagnosis and treatment occur within our rural communities. So everybody's great, very excited about those things. We want to, again, thank you very much on behalf of the National AHEC Organization and, more importantly, of all our Crossroads AHEC, Utah AHEC, and how they brought you to us. So that's been great. We look forward to next week to hear what else you have to say. A reminder for everyone, again, because we don't have continuing education credits, if you can utilize a certificate, please be sure to let us know. You can put it in the attendee chat. We're able to download all of that information. And you can always send an email to info@ntc.nationalahec.org, and we'll be happy to send you one that way. So again, Deanna, thank you very much for an outstanding webinar.
Gretchen.
And we will talk with you next week on our next webinar. Thank you, everyone, and have a great rest of your week.
Thank you.
Bye-bye.
You will